cardiac implantable electronic device in cardiovascular disease with or without dysrhythmia. I introduced the first three speakers. The first speaker is Dr. Jui Chen from Taiwan. He's a staff cardiologist, Division of Cardiology, Department of Internal Medicine, and National Cheng Kung University Hospital, Tainan, Taiwan. So Dr. Chen, please go ahead. Dr. Chen, please. Your sound is off, so would you please on the line for the sound?
Dr. Chen, please open your sound.
Please open your sound. Your sound is off.
Okay.
Yeah, that's okay. And slide, please.
Okay, can you see my slide?
Okay, that's good.
Yes, I will start my topic. Since Chairman's introduction, I'm Dr. Chen from Taiwan. My topic is best practice of permanent artificial pacing modality in symptomatic sinus node dysfunction in the high degree of complete AV block. Minimal RV pacing, biventricular pacing, or his bundle, left bundle branch area pacing. So the first part is minimal RV pacing. The current ESC guidelines show that if patients in sinus reason or atrial fibrillation with permanent or paroxysmal third or second degree type 2, infranodal 2 to 1 or high degree AV block, even asymptomatic permanent pacemaker is indicated in level 1C. In patients with symptomatic sinus node dysfunction, including tachycardia, bradycardia syndrome, pacemaker is also indicated with the level of 1B. Also, the current ESC guideline also recommended that minimization of unnecessary ventricular pacing through programming is strongly suggested with the level of 1A. Why prevention of unnecessary RV pacing is very important. We know that unnecessary RV pacing will reduce the generator longevity. Numerous studies has demonstrated unnecessary RV pacing can exacerbate certain heart outcome. In the DAVI trial and the intrinsic RV trial, unnecessary RV pacing will increase heart failure hospitalization and the mortality. In the self-pace trial, unnecessary RV pacing will increase persistent atrial fibrillation risk. In the MOS trial, unnecessary RV pacing will increase the chronic atrial fibrillation and the heart failure risk. Based on these studies, the ESC guidelines suggest that for patients with sinus node dysfunction, the default setting of mode is DDD or DDDR mode with AV management. It also suggests that AV delay programming should avoid more than 230 milliseconds, and the specific algorithm to avoid reduce unnecessary RV pacing is very important. So in Medtronic device managed ventricular pacing or Biotronic AV hysteresis or ISR plus also suggested. The second part is biventricular resynchronization therapy. Because many studies has shown that if the patient had a heart failure, LV ejection fraction less than 40 to 50%, and the AV block or RV pacing more than 20%, regardless of NYHA functional class, CRT or bivalent pacing is suggested to use in such patients, and the evidence level is 1A. However, in many countries, because of the insurance issue, conventional pacemaker is still the standard therapy for this kind of patient. This slide shows the management of AV junction ablation in patients with permanent atrial fibrillation or persistent atrial fibrillation unsuitable for AF ablation. For this patient, if well-controlled heart rate is achieved, and the patient are the candidate for CRT and the QRS duration more than 130 milliseconds, and the bivalent patient is more than 90 to 95%, no AV junction ablation is needed. If biventricular patient less than 90%, AV junctional ablation is suggested with 2A indication. If the patient was candidate for AV junction ablation and the LV ejection fraction less than 40%, CRT is class 1 indication. If LV ejection fraction more than 40%, the less than 50%, CRT is class 2A indication. His bundle patient is an alternative option with 2B indication. If the patient had the normal LV ejection fraction, conventional RV patient was suggested with 2A indication, and the CRT or his bundle patient is 2B indication. The third part is conduction system patient, including his or the bundle branch area patient. This slide shows the his bundle patient system. Usually, we can find the his potential and the localized his. It could be classified to atrial or ventricular his patient sites. Also, it could be non-selective or selective his patient. Irrespective non-selective or selective his patient, more narrow QRS duration could be obtained. However, the relative narrow setting outputs may limit the usefulness of his patient. The team of Dr. VJ has shown that long-term performance and the safety of his patient in 2019. The capture threshold will be increased after implantation for 3 years, even more than 2.5 voltage. The percentage will be near 30%. This phenomenon will limit his patient use in the future because it will lower the battery longevity significantly. Based on the possible high threshold after implantation of his patient, a backup RV patient lead may be indicated. The advantage include increased safety, better sensing, and the better patient threshold. The disadvantage include higher cost, more hardware, more risk associated with the additional lead, more complex programming, and off-label use. So the current ESC guideline recommended that when patients are treated with his bundle patient, programming should be tailored to its specific requirements. A RV lead as a backup lead is 2A indication. His patient can be considered as an option for CRT candidate in whom CS lead is unsuccessful. It may be used in combination with a ventricular backup lead with patients indicated for pass and ablate strategy. The classification is 2B, and it may be alternative to RV patient with AV block with LV ejection fraction less than 40%, when more than 20% ventricular patient is anticipated, but the level is 2B. The another conduction system patient is left bundle branch area patient. The definition of left bundle branch area patient is by anatomy, location, and the EP characteristics. The current ESC guideline indicated that alternative RV patient site include patients from the RVOT, the mid or high RV septum, his bundle patient, parahesian patient, and the left bundle branch area patient, which include LV septal patient and the left bundle branch patient. This slide shows the detailed anatomy of left bundle branch area, include the left bundle branch trunk, left anterior fascicle, left septal fascicle, and the left posterior fascicle. The typical QRS pattern in each location was shown here. The difference is in QRS axis and the precordial R-wave transition. The first published case is from Dr. Huang in 2017. The clinical outcome of this case showed more stable threshold and the sensitivity. Also, the echo parameters, the serum BNP level, all improved after the first left bundle branch area patient. So, the his or left bundle branch area patient would be compared to see which modality is better. Most important is physiology. His bundle patient will preserve RV and LV synchrony, but left bundle branch area only LV synchrony. However, more technical challenge in his bundle patient, more increased chronic threshold in his bundle patient, and the more complex programming in his bundle patient. Although left bundle branch area is better than his bundle patient in several aspects, including no RV backup lead is necessary, longer battery longevity, and the relative easy AV junction ablation. Left bundle branch area has more septal perforation risk. However, these complications seldom cause life-threatening events. Therefore, compared to his bundle patient, left bundle branch area patient has more benefits in our daily practice for patients with indications for permanent pacemaker implantation. Furthermore, bilateral bundle branch area patient has been developed, and there may be an alternative in the future. However, currently, no clinical relevant data has been published. We did not know whether bilateral bundle branch patient is superior or inferior to his patient or left bundle branch area patient. This slide shows the Dr. Huang's suggestion. If maintenance of ventricular synchrony is required, the high percentage of ventricular patient is needed. The first target site is proximal his bundle, then distal his bundle, then left bundle branch area. The final is LV septum. If YQS with typical complete left bundle branch block and the CRT is required, the target sequence is the same to the patients with narrow QRS. For right bundle branch block, there is no well-established answer. For intraventricular conduction delay, his bundle patient or left bundle branch area patient could be the choice. If all failed, heart CRT or LUT CRT is the final option. Otherwise, the current Jan-Seeger patient protocol also suggests that if the patients with normal his concussion or right bundle branch block, his bundle patient is the first choice, and then if threshold more than 1.5 voltage, the bundle branch area patient is suggested. If the patients with HV block or left bundle branch block, left bundle branch area patient is the first choice. And if combined reduced LV ejection fraction or heart failure, CRTP is still first suggested. Here, I will show you two cases. The first one is a 23-year-old female patient with congenital high-grade to complete AV block. This is her 12-lead ECG, complete AV block with junctional escape bits with right bundle branch block pattern and the left posterior fascicular block pattern. 24-hour Holter documented intermittent junctional escape reason and the ventricular escape reason. Based on the current opinion of expertise, I choose to implant a his patient system for her and the QRS duration is 100 milliseconds. Compared to her baseline ECG, more narrow QRS was obtained. Considering the possible increase in the threshold, the 2-year follow-up data was shown here. No significant increase in RV threshold was noted. The second one is the 24-year-old female patient with congenital 2-to-1 to high-grade AV block. Symptomatic exercise intolerance was also noted. This is her baseline 12-lead ECG showing 2-to-1 AV block with right bundle branch block and the left posterior fascicular block pattern. The QRS duration is 120 milliseconds. Her treadmill exercise test showed the maximum heart rate was 76 BPM, which was far away from her maximum prediction heart rate. The electrophysiology study showed the prolonged HV interval, and the infrahesion block was also noted. According to current expertise opinion, I implant the left bundle branch area pacing for her, and the QRS duration is 118 milliseconds, which is shorter than her baseline. So finally, this is the final slide. The take-home message was, for patients with symptomatic sinus node dysfunction, minimized RV pacing is recommended. Many default settings, such as managed ventricular pacing or Medtronic, was suggested. For patients with symptomatic high-grade or complete AV block and the reduced LV ejection fraction, whether AF or not, CRT is first recommended. His bundle pacing or left bundle branch area pacing may be the alternative. For young patients with symptomatic high-grade or complete AV block and the normal ejection fraction, his bundle or left bundle branch area pacing may be the future direction. And I think shared decision-making with your patient is very important. For elder or multiple comorbidities patients with symptomatic high-grade or complete AV block and the normal ejection fraction, conventional RV pacing may be suitable. However, his bundle pacing, left bundle branch area pacing, or leadless pacemaker may be the future direction. And I also suggest shared decision-making with your patients. This is my topic and case sharing. Thanks for your attention.
And Dr. Chen, thank you for your presentation.
Yes.
And I have a few questions, especially about left bundle pacing.
Yes.
I know that there needs a specialized catheter to put the leads on the left bundle. So what kind of catheter is available in Taiwan?
In Taiwan, we have a choice Medtronic and Biotronic. We can use these two types of launches and leads for left bundle branch area pacing.
So is there any difference to use between persons or cases?
I think if you do this procedure more than 20 to 30 cases, I think you will be familiar with this procedure, and it's not different from your daily practice conventional pacemaker implantation. I think more than 20 to 30 cases, you will very familiar with this procedure. And I think the septal perforation is very rare in my daily practice.
I heard that there is some kind of a learning curve for left bundle pacing. What cases would be enough for familiar with left bundle pacing?
I suggest in the beginning, you can choose the sick sinus syndrome case because the ventricular pacing is not very dependent. And if the procedure is familiar with you can be familiar with this procedure. You can try AV block patients. And in my daily practice, no RV lead backup is needed currently.
Okay, one more question. I heard that sometimes the left bundle pacing, initially the QRS is very narrow, but after a few months later, the QRS is slightly widened after, as compared with the first initial presentation. Do you experience such kind of cases?
Yes, but I think if the pace QRS duration is less than 130 milliseconds, I think it's enough for these patients, because currently the CRT indication is left bundle branch block pattern with QRS duration more than 130 milliseconds. So I think left bundle branch area patient is the future direction.
Okay. Is there any questions from the speakers? If not, let's move to the second speaker. Thank you, Dr. Chen.
Thank you.
Yeah. The next speaker on the agenda is Dr. Salem, but he's a little bit late for connecting online. So I'll move to the third speaker. The third speaker is Dr. Paul C. Quintua from Philippines, and he is head of electrophysiology in Asian Hospital and Medical Center, co-head in Makati Medical Center, Philippines. And his topic today is wearable ICD, permanent ICD, or CLT ICD following acute myocardial infarction, complicated with heart failure with reduced ejection fraction, timing and candidate identification. So please, Dr. Quintua.
Okay, can I share my screen?
Okay.
So good afternoon, can you hear me?
Okay, you're very clear.
Thank you. Thank you for having me. I'm very grateful to be here. So we'll be talking about wearable ICDs, permanent ICDs or CRTDs following AMI or acute myocardial infarction complicated with HFrEF, timing and candidate identification. So I have spoken in behalf of different pharmaceutical and device companies, but this talk is not a sponsored lecture. So sudden cardiac death usually is caused by ventricular tachycardia or VFib, sometimes PAEs, and more than 80% in studies occur in patients post-ACS or those with underlying CIED. So they belong to the very high-risk population. Majority, 83%, occur after discharge, mostly likely because of the adrenaline surge, because they're now more ambulatory, while in the hospital, they're usually bedbound. And 1 out of 3 out of hospital arrest is attributable to VT or VF. And the survival is dismal, less than 20%. So we need to do better. One strong predictor is LV systolic dysfunction. As you can see in this particular graph, the different studies show the total mortality and sudden cardiac death mortality at the end of the study period. So in the low EF population, the total mortality is quite high, 15 to 40%, and about half of this is due to sudden cardiac death, hinting that EF may be an important risk predictor for sudden cardiac death. So what about specifically post-MI patients, the topic of this talk, complicated with LV dysfunction? You can see here the sudden cardiac death rates in post-MI patients with LV dysfunction post-MI. The mortality, total mortality is about up to high as 32% in the MADIT. And arrhythmic mortality is still again 50% or thereabouts of the total deaths. So, and here's the data showing the LVEF, which is inversely related to the risk of sudden death, meaning the lower the EF, the higher the risk of sudden cardiac death. So as you can see here, if the EF is less than 30%, the risk of sudden cardiac death is highest at 7.5. And if the EF is above 40%, the risk is little bit lower at 2.8%. So, but as you can see, 56 or more than 50% of all sudden cardiac arrest victims had an EF of more than 30. So it's a predictor, but it's not the best predictor out there. Here's where the defibrillators come into play. Earlier trials in patients who did not yet have a secondary prevention indication. So for example, no VF or no aborted sudden cardiac death yet. But they already have high risk features because they are post-MI and they have heart failure and low EF. Have shown that if you implant an ICD at an appropriate time, the overall death as well as the arrhythmic death decreases compared to just medical management alone. And just look at the MUST trial. So this is a small trial, but the arrhythmic death was reduced by 73% once the ICD was implanted. MADIT-2 also had a good data, 62% reduction in terms of arrhythmic death and 31% in terms of overall death. So we'll just look at two studies in detail so that we can see where the recommendations come from. So MADIT-1, one of the granddaddies of the studies, involved 196 patients more than 3 weeks post-MI. So remember that. With low EF of at least 35%, non-sustained VT, and a positive VT inducibility study. And they randomized the patients to either ICD implant or conventional medical therapy, largely amiodarone. So as you can see, in the EPS positive patients with an ICD, absolute mortality was reduced by 23% compared to medical therapy. And you just need to implant 4 ICDs and you're saving already 1 life. In the MADIT-2, this one, they did without the inducibility, which is controversial, and they involved 1,232 patients. Again, not immediately post-MI, more than 1 month, but most were more than 2 years post-MI, low EF, 30% or lower, randomized to either conventional therapy, which is medical, versus ICD. And as you can see, mortality was again reduced 20% in the conventional, and there's a 31% relative risk reduction in the defibrillator arm compared to the conventional. And you needed 15 ICDs implanted to save a patient's lives. So this is quite significant because in the other medical management, the number needed to treat to save 1 life is about 30 to 50, and rarely in the 20s. So this is pretty good. So this is the latest AHA/ACC primary prevention guidelines. So patients with ischemic cardiomyopathy or ischemic heart disease, you look at the EF, which is the main discriminator, if it's at least 40 or below, and if the patient already had an MI, but it's already post 40 days after the MI, or if the patient had a revasc for the MI and it's already more than 3 months post-revasc. And then you look at, is there an ICD recommendation? So if you follow the MADIT-1 trial, you do an EP inducibility. If there's an inducible sustained VT, then the patient falls in the class 1 category for ICD implant. If the patient's EF is lower, so for example, 35% or lower, but more than 30%. And then there's already a class 1 recommendation if the patient's NYHA class is 2 or 3. If the patient's EF, if the patient's NYHA class, is 1, then the patient's EF should be lower at least 30% or below. So as you can see, this seems to be a bulletproof recommendation, except that there's a 40-day wait, post-MI if there's no revasc, and 90-day wait if there's a revasc done. So where did this recommendation come from? So before we answer that, we just look at the data coming from the large trials. So this is the Valiant trial, so valsartan in acute MI trial. And as you can see, this is the mortality, risk of sudden death on the y-axis, and months after MI and the x-axis. If the EF is very low, like less than 30% or equal to 30%, the mortality is very high. But in all the quartiles of the mortality, or the EF, sorry, the mortality was highest during the first month. So highest rate of sudden cardiac death during the first 30 days post-MI, and this declines and plateaus after a year, even in those patients with an EF of more than 40%. So just remember, MADE-IT 1 and 2 and MUST trials recruited patients who were more than a year after the MI, majority or a mean of 18 months. So they did not really study patients in the immediate post-MI period. So we don't have much, or we can't rely on the data of the MADE-IT 1 and 2 and MUST to answer the question. So are there studies involving the immediate post-MI period? So there are two. So we'll look at them now. And this is the first is the Dynamite trial. So this is 60 to 40 days post-MI, low EF, less than 35%. And there's an added criteria, impaired cardiac autonomic function. And again, classified as high-risk group. And they were randomized to either ICD or medical therapy. And as you can see here, in the ICD, the mortality rate is very similar to the control group. At the latter part, it actually overtook the control group mortality. So they hypothesized that maybe the ICDs did save those patients from dying very early on because the arrhythmic death was highest. But later on, because they survived and had maybe progressive heart failure, they will succumb to the heart failure and die within weeks or months. So this is a negative trial, or meaning it did not show benefit in terms of ICD placement in the immediate peri-MI period. So this is just to highlight. So the ICD group had less arrhythmic death, that is expected because the ICD prevented some arrhythmic death, but higher heart failure deaths, leading to a similar overall all-cause mortality. So one interesting finding there was the higher proportion of BF. So BF usually is caused by ischemia and not by scar. So as we know, if there's a high ischemic burden, then the patient will have recurrent BF. And if the ischemia is not resolved, then the defibrillator might shock the patient multiple times, but the BF will keep coming back. So the questions during the presentation of Dynamite was that, is the BF a independent marker for mortality? So maybe the patients who died actually had a higher mortality because they were sicker, and even an ICD implant could not have saved them because the prime cause of the death or the ventricular arrhythmia was ischemia and not scar. So ICD shocks were highest in those they presumed highest risk and sickest patients. So, but the bottom line is no benefit in the immediate post-MI time. So the second trial is the IRIS. So the IRIS enrolled 898 patients, 5 to 31 days post-MI, more generous in the EF, at least 40%, and then two predictors, a high heart rate, first recorded heart rate of at least 90, and a non-sustained VTAC on the 24-hour Holter monitoring. So here, again, as you can see, the ICD group deaths and the control group were not very different. So 116 in the ICD and 117 in the control. So that means that there's no significant benefit or protection in the immediate post-MI period when a defibrillator was implanted. So another question maybe is, should we wait? So why wait? Why wait 40 days post-MI if no revasc, or 90 days post-MI if there's a revasc attempt or made? So because there's some studies that show that maybe the EF, which the guidelines is hinging on as a discriminator, may improve with medical therapy and revasc. So here, in this particular trial, so this is the PREDICTS trial. This is a trial after the VEST trial. So they have had the same population immediately after the vest. So patients were randomized there, and they called the data. And as you can see here, after the wait, 43% had the persistently severe or EF of less than 35, but more than 50%, 57% had an improvement. So 26% even had an improvement as much as more than 50% of EF. So at that particular waiting period, the EF is recovering. More than 50% initially thought to have an ICD indication would have no more indication after the waiting period. So they identified some patient characteristics that might predict which patients will improve and which will unlikely improve. So maybe it's fortuitous. So the question now is, what if we just give beta blockers and let the beta blockers prevent sudden death while waiting? So just remember, in the SCUD-HEF, though the population is mixed, it's combination of non-ischemic, ischemic. Amiodarone did not improve mortality compared to placebo. So now we default to the beta blockers. If we look at the beta blockers studied for heart failure, MERIT-HF involving metoprolol succinate, CBIS-2 involving bisoprolol, Copernicus involving carvedilol, you can see that there's a mortality benefit, but the mortality benefit almost all came after 3 months. So the mortality risk or overlap with a placebo in the first 3 months. So maybe it's not a good idea just to give a beta blocker during the waiting period. Of course, we're giving it long term, but there's no evidence as of now that it might be very beneficial in the immediate 3 months or so period that we're giving it while waiting for an ICD. So now comes the logic about what we call a wearable cardioverter defibrillator, or WCDs. So the WCD has been FDA approved in the United States since 2002, and this one is made by Zoll, and it has two components: the garment and the battery pack. So the garment is the one that records and identifies the arrhythmia and also shocks the patient. The battery pack, it's just like a small tablet. You can actually answer questions in it and have some control over the device, and it will deliver the energy to shock the patient. The problem with it is that there's some limitations, including compliance, which we'll see later, which is a very big issue, and patient habitus. So for example, if the patient is obese, the patient might not have the right fit, or the device might not even actually fit the patient, so it might be useless. And there's no pacing capabilities. So for example, we know that if we have an ICD implanted in a patient with structural heart disease, ischemic heart disease, we need the ATP or antitachycardia pacing to limit the shocks. And of course, if there are medicines that might cause bradycardia, we also might need post-shock pacing. So this one cannot provide that. And in patients post-CABG, for example, healing chest wounds might be an issue. So there are 2 pilot studies that they did before the very only one, the big RCT. So the WERIT trial and the BIROAD. So WERIT trial, EF of less than 30%, recent MI, VT within 48 hours, and high-risk feature like a syncope or aborted SCA at least 48 hours after the event. So they already had a low EF post-MI, but did not meet eligibility criteria for an ICD. BIROAD, longer time from MI or bypass, so within 4 months. VT within 48 hours of bypass. EF less than 30%, at least 3 days post-bypass, and other high-risk features. So the BIROAD included patients who had an ICD indication, but either they refused or they were still waiting for the ICD. For example, they have an infection, so they're waiting for the infection to heal, etc. So total number of patients, less than 300, 12 deaths. 6 deaths were not sudden cardiac deaths. But this is more important. 24% discontinued due to discomfort, and 5% five patients had sudden cardiac death, but they were not wearing the device. So really, compliance is an issue. And one sudden death wherein the patient was not wearing the device appropriately. So it did not save the patient. So now comes the RCT. So the VEST trial involved 2,300 patients post-MI, low EF, randomized 2:1, wearable defibrillator versus medical therapy. Of course, the primary endpoint is looking at reduction in ventricular tachyarrhythmias or death suddenly, presumed to be due to ventricular arrhythmias. And as you can see, the confidence interval crosses the line of unity, and there's no significant difference between the control group, sudden cardiac death rate, versus the device group. So they are almost overlapping. So the explanation for this is actually poor compliance. So in the treated analysis, meaning if we just look at the data involving patients who actually wore the life vest or the WCD, it was actually associated with a 57% reduction in arrhythmic death, impressive, and a 70% reduction in total mortality. But of course, we cannot just disregard the fact that most people were not wearing it. So the conclusion was that if we take all the data and not just the patients who were wearing it, it did not significantly decrease the arrhythmic death. So there's some limitations. 5% of the cause of deaths were indeterminate and difficult to really determine if the death was truly arrhythmic. So some died of PEAs, so they had a difficult time adjudicating. And significant decrease in the use due to discomfort. And there are also a lot of complaints because of frequent audible alarms. So we just look at and compare the compliance because this is the main issue in the US nationwide registry versus the VEST. So the VEST is RCT, this is non-RCT. You can see the mean daily use in the nationwide registry is 20 hours. If you're not using it, it's ineffective. In the VEST, the mean was only 14 hours. And if you look at the discontinuation rate, as early as 2 weeks, there's already 20% discontinuation. So patients were not wearing it because of discomfort. They can't sleep properly. They can't wear it while swimming or taking a bath or doing exercise. And the discontinuation was actually reached up to 80% at the end of the trial, 3 months. So really, it's a good device, except that it's really not comfortable and the discontinuation is hurting its benefit. So we'll just look at this meta-analysis involving 28 studies. So again, only the VEST was the RCT, the rest were observational. This involved 32,000 plus patients, but 20 of the studies were either sponsored by ZOL or used data from ZOL. And if you look at the data comparing the overall appropriate shocks per 3 months is 5 average. Ischemic cardiomyopathy had the highest appropriate shocks in 3 months, 8 per 100 persons. But the VEST is only 1 per 100 persons appropriate shock in 3 months. So the observational studies had higher appropriate shocks compared to the RCT. So the most likely explanation is selection bias. So they're selecting patients who they think had a higher chance that they will use the device to make it look better. So in 2016, the AHA released a scientific statement wherein you can use it as a 2A recommendation if, for example, the patient is waiting for definitive therapy like cardiac transplant or LVAD, and the patient is to be sent home and there's no more monitoring in hospital. Or if, for example, the patient had an ICD, but you needed to explant it because of an infection, you can have the patient wear the life vest while waiting for the infection to abate. Or if there's no ICD yet, but the patient had an indication for an ICD, and there's an ongoing infection and you're still waiting for the infection to resolve prior to the ICD implant, there's a 2 recommendation for that. So briefly, we'll just discuss the CRTD because this topic has already been discussed in the first talk and will be discussed again in the last talk. So in patients who will need a defibrillator, you should also look at the QRS morphology. And if the QRS morphology is a left bundle branch block and the QRS duration is at least 150 milliseconds or more, and the patient is in sinus rhythm, you can actually opt to implant a CRTD instead of just a defibrillator. The CRT will confer an additional benefit compared to the defibrillator, so the benefit is additive. So the less the ventricular dysynchrony as proven by the QRS morphology, meaning if it's a non-LVBB, or the QRS duration, meaning if it's less than 150, the recommendation is less. So we're almost at the bottom of the part of the lecture. So how can we do better to save lives? So we know that CRTs and defibrillators save lives, especially in the higher risk population, including post-MI and HFrEF. We know that EF predicts patients who will die suddenly. It's a predictor not only for arrhythmic death, but also for heart failure death. But there are other risk stratifications that we can use. So remember the data in the Valiant trial. Even if the EF is above 30, the risk of sudden cardiac death is still high. And more than 50% of those who died suddenly had an EF of more than 30%. So maybe in the future, we can use better risk stratification, including a cardiac MRI, to grade or measure the scar of the patient. And secondly, we know that wearable ICDs can actually work as long as the patients are using them. If they're not using them and they are ineffective and useless. So in the future, maybe there will be better designs of wearable ICDs that will improve compliance, and then maybe they will have a higher recommendation because they will be proven to save lives in terms of total mortality risk benefit. So number 3, maybe we need better medicines to intervene or improve the ischemia. So remember, in the Dynamite and Iris, there's no benefit, and those who got shocked for VF actually had a worse outcome because the thinking is that the arrhythmia is not just a scar VT or a scar related arrhythmia. It's because of ischemia. So if we are able to reduce the ischemia, then those patients would have survived enough or long enough to get a defibrillator in the future so that they will be protected from a scar ventricular arrhythmias. And we need medicines that improve the LVEF and work faster in preventing sudden cardiac death. Remember the lesson of the beta blockers in heart failure. They don't have a survival benefit very early on. They needed more than 3 months to provide protection. But in, for example, in the SGLT2 inhibitor trials, they actually have a survival benefit and improvement in LVEF very early on, as little as less than a month. So maybe with more use of SGLT2 inhibitors, we will be able to save more patients. And then they might not need a defibrillator long term. So I think with this, I'll end. Thank you.
Yeah, thank you for your presentation. I have a simple question. At the end of the presentation, you mentioned about the recent medications, and we have sacubitril valsartan and SGLT2 inhibitor. Those drugs are not available in the study period of SCOT-HEFT or MADE-IT.
Yeah.
So how long and how many drugs do we have to use before implantation of defibrillator? How do you think about it? And what is your usual practice?
Yeah, so if you look at the Danish trial, so Danish registry used some ARNI, but not the SGLT2 inhibitors. And their uptake for beta blocker and ACE inhibitor is very high, more than 90%. Of course, the comment for the Danish trial is it's not applicable to this talk. It's non-ischemic cardiomyopathy group. And half of them had a CRT that was not part of an ICD. So the comment was that the CRT, the improved survival. So, but it's an example wherein the patients were the medications were almost all there. The uptake or the compliance for the medication is very well. So you're correct that we don't have data. The data that we are relying on is on patients who were poorly medicated or, well, not as good as what we want. For example, the MUST trial, the beta blocker usage was just 29%. So if the theory is if they use the beta blocker more, then the benefit will have been maybe not as good. So, but for the guidelines, as long as you give guideline-directed medical therapy for 3 months or 90 days, so that includes a beta blocker and an ACE or an ARB, then it's already what we call guideline-directed medical therapy. But you're correct. Maybe in the future, we'll have more data. If, for example, if we include the ARNI and the SGLT2 inhibitor, maybe after the 3-month waiting period, more recovery will be seen and maybe less people will need ICDs. But as of now, we don't have data on that. So, but we're very excited to maybe have a study and be a part of that study.
Thank you.
Thank you.
Dr. Luisi, do you have any questions?
Yeah. Good conclusions, Paul, my friend, Dr. Kitu. I wanted to ask you, Dr. Zhang, about the wearable ICD, but maybe we'll hear from the other speakers later because it's not available in the Philippines as well. So it's very promising, but as you have mentioned, what's key is risk stratification, right? You mentioned about cardiac MR. Could you share briefly how often you actually do it in clinical practice? I guess it's about scar quantification, right? And in lieu of cardiac MRI, do you sometimes use other diagnostic imaging for that purpose, like myocardial perfusion scan, for example?
Yeah, in terms of LVEF, it's not just limited to echo. So you can use cardiac MRI, MPI, but there's a class 2B recommendation. For example, if you think the sudden cardiac death risk is a bit higher than what the EF is showing, I can use a class 2B recommendation to look at imaging, including cardiac MRI. But as of now, none that I know of, that there's a recommendation cut off for scar burden. So for HOCM, for example, we do have some recommendation and some data, but for post-MI ACS patients, we don't really have data. So remember, this is just 2 minutes. So remember, if you have ischemic heart disease, if there's no revasc, we don't expect really benefit. So we do expect benefit in the revasc. If it's a non-ischemic cardiomyopathy, we wait 3 months because the SCOD-HEF exclude patients during the immediate 3 months upon diagnosis, and there's a chance that it might be reversible. So ischemic heart disease patients, higher risk, we don't expect benefit if there's no revasc done because the etiology is not corrected. So remember the problem with ischemic heart disease is that the VF is actually higher than in the non-ischemic cardiomyopathy group, and this is drawn by ischemia. So cardiac MRI usually will show scar. So this might risk stratify patients who might have, for example, an EF of 40%, but a big scar on the MRI and maybe at high risk of scar VT in the future. But for ischemic in the waiting period, I'm not looking at it as a very helpful modality. But in the future for scar VT after a waiting period, maybe if the EF is iffy but you get a large scar in the cardiac MRI, maybe they will have some studies wherein there's a threshold and you can already implant an ICD.
Okay, thank you. Thank you very much.
Thank you.
So let's move on to the next speaker. The next speaker is Dr. Hidehira Fukaya from Japan. He is Junior Associate Professor in Kitasato University School of Medicine, and is Chief of EP Cardiology in Kitasato University Hospital, Tokyo, Japan. His topic today is best practice of leadless pacemaker implantation in symptomatic bradyarrhythmia, candidate identification and troubleshooting. So please, Dr. Fukuya, please go ahead.
Thank you, Chairperson, ladies and gentlemen. I'm going to share my screen. Can you see my slide?
Yeah, we can see your slide and hear you clearly.
Okay, thank you. Today I'm going to talk about the leadless pacemaker and the potential candidate identification and troubleshooting. Here are my disclosures. As you know, in 2016, a paper about the leadless pacemaker was published in New England Journal of Medicine. And after this paper, our practice about the bloody arrhythmia has changed. Today's main talk is about the candidate for micra and complication and troubleshooting for micra. So leadless pacemaker is now an established alternatives to traditional transvenous pacemaker, especially in a patient who only require a brief period of pacing or only require ventricular pacing. There's a lot of reason to the leadless pacemaker. For example, I think this is the most important thing is the patient characteristics. If the patient only has transient arrhythmia or higher age, is a good candidate for micra, concerning the battery longevity issue. Micra implantation does not need the skin sutures, so the patient with dementia, patient having cosmetic or occupational lesion, and active lifestyle is another candidate for the micra. Another issue is anatomical problem. The patient have the vascular occlusion due to residual lease, thrombus, or vascular shunt, or patient on hemodialysis, or a patient having a risk of pneumothorax. They are all good candidates for micra. And also the patient after complication of a traditional transvenous pacemaker, for example, post-lead extraction or pocket infection or multiple residual lease. Also, the patient have a higher risk of traditional transvenous pacemaker implantation. For example, the infection patient or compromised host, such as taking an immunosuppressive agent, or patient having an issue about the tricuspid regurgitation also. So, however, the only one problem of this micra was the only VVI mode could have been available. This paper was just published in 2020 from Japan. They compared to the clinical event between the VVI micra pacemaker and transvenous DDD pacemaker. As you can see here, they evaluated a couple of clinical events, but the heart failure readmission is higher in the VVI leadless pacemaker compared to DDD transvenous pacemaker. So VVI mode is may have some trouble. So a couple of years ago, the micra AV was launched. This pacemaker can AV synchronous pacing. Let me explain about the detection of the atrial signal between the TV pacemaker and micra. As you know, TV pacemaker can detect the atrial activation by electrical sensing with LA lead. On the other hand, the micra can detect the atrial signal by mechanical sensing by accelerometer on the device. Micra has the 3 different directions of accelerometer which can detect the atrial blood flow like this. So in this paper, the Micra AV can achieve the synchronous AV pacing over than 80% in the AV block patient. So micro AV might change our practice. So the merit of the micro AV is that we can choose the VDD mode in this micro AV. Now, this system, over than 80% of synchronous pacing can be achieved with multiple accelerometer on this micro itself. However, we can still have some problem on this micro system. As you know, the longevity of the ballet is unsolved issue. You know, the micro cannot exchange or remove easily. Another issue on micro AV, the implantant position is not easy to manipulate. So getting a good A signal is to be by chance. So next topic is the complication of troubleshooting of the micro. As you know, the overall complication rate is less in micro than the traditional transvenous pacemaker. However, the type of complications are different between micro and transvenous pacemaker. In terms of the pericardial effusion, probably micro is more. The infection is in micro is less, and of course, lead trouble. Micro doesn't have any trouble in lead trouble. So let me explain about the pericardial effusion. This is the first paper that I already shown you. The overall complication, major complication rate was less than 4% for 1 year. Looking at the detailed complication in this study, the traumatic cardiac injury and cardiac perforation or effusion was reported 1.6%, which was the most frequent complication. So after the launch of the micro in Japan, Professor Kyoko Soejima reported that initially experienced the micro implantation in Japan. As you know, our Asian population are the small and lean population. And the case number was a little bit small, but all cases were successfully implanted the micro and there are no complications. So the micro was safely implanted even for a small and lean Asian population. But was it real? Medtronic quarterly reported the incidence of the cardiac tamponade population in Japan. As you can see, just after the launch of the micro, the incidence of cardiac tamponade population rate is 1.4%. It is not so low. Of course, the complication rate gradually decreased, but there is some complication there, about 0.6 to 0.8%. Looking at the timing of the cardiac tamponade overpopulation, about 55% of this complication occurred during the operation. The remaining 45% complication occurred after the operation. So we should carefully observe the patient at least within 24 hours. This paper evaluated the predictor for pericardial effusion during the microimplantation. Totally 2,800 patients were evaluated in the study, and the overall rate of the pericardial effusion was 1.1%. It is not so high. I think it's acceptable, but in this 32 patients, 3 patients died within 30 days. So fatal rate is about 9.4%. It is quite high. So the operator should consider not to get carefree perform the microimplantation without this complication. So they evaluated some factor associated with the pericardial effusion. As you can see, the low body mass index, less than 20, at age over than 85, and concomitance with the COPD is are associated with the pericardial effusion, which already reported the same factors. So they made risk scores using these factors. They were divided in 3 categories: low, intermediate, and high risk. As you can see, in the patient with high risk pericardial effusion patient, probability risk of pericardial effusion more than 4%, so which is quite high. So, and also, the repeated deployment is another factor to increase the pericardial effusion. As you can see, the patient with a low risk patient, multiple repeated deployment does not increase the pericardial effusion. However, intermediate or high risk patient, repeated deployment of micra did increase the pericardial effusion. For example, over than 5 times deployment of micra in high risk patient, the probable effusion, pericardial effusion rate is over than 20. It's quite high and maybe sometimes fatal. So we should not repeat the deployment. We should try to deploy the micra once. So repeated deployment may have other risk. I'm going to show you our case: 75 years old female with transient AV block. And we deployed actually twice or 3 times because of the unsatisfactory threshold. Finally, we could implant the micra successfully, but about 1 month later, she underwent coronary angiography because of the other reason. As you can see, minor coronary perforation were observed. Actually, I reported this case on Circulation Journal. Fortunately, this cardiac perforation did not affect her hemodynamics, but repeated deployment of the micra may cause a severe complication. So my message is the once deployment is better. So I'm going to show you the next case. She had post DVR and TAP, tricuspid annuloplasty. As you can see, she had a giant right atrium and a small annulus of small tricuspid annulus. And you know, it is very difficult to pass through the micra to RV, but fortunately we can do that, but it was so difficult to manipulate the micra on the RV. So we repeatedly check the good position with injection with no contrast, but it was so hard. So finally, after the 8 or 9 times injection, we finally found a good position here. And then we deploy the micra here. So we could get the good pacemaker parameters, and there are no complications. So my message is one deployment, not repeated deployment micra to reduce the complication. So I'm going to show one good paper from Japan. Dr. Togashi reported successful implantation tips. They evaluated the angle of the microimplantation with the fluoroscopy. They evaluated the 104 deployment, and they evaluated the good threshold or not satisfactory threshold. As you can see, more flattened position of micra is better, better position. They evaluated the cutoff value of this angle, the 6 degree in RAO, 30 degree of LAO is the best cutoff value to get the better acceptable threshold. I'm going to show you, I'm going to a little bit explain about this angle. This is my case. I think this it was an easy case to implant the micra, but you know, I put the micra middle of right ventricle. As you can see, I got some gooseneck shape like here. The angle is not so bad. However, I checked the aerial view. The micra position was not good. The axis is a little bit vertical. Therefore, I pushed forward a little bit. And then I got the better position like this. The better gooseneck and the lower angle in RAO view. And good position in aerial view, much flattened angle. And then we put the micro here and we successfully implanted the micro one deployment. So next topic is the infection about the micro implantation. This paper was from Duke University. They implanted the micro after the device infection. About 40% have the pocket infection, and the remaining 60% patient have a bacterial anemia. In total, 39 patients underwent the lead extraction device extraction, then microimplanted. Interestingly, over the 2-year follow-up, there were no recurrence of infection at all. This paper was from China. They also implanted the micro after device infection. Actually, they are all only pocket infection, but this paper is very interesting. The micro was implanted immediately after the device extraction within the same operation. I think it's a little bit higher risk, but they reported that no recurrence of infection after the micro implantation. So therefore, the patient after device infection are a good candidate for micro implantation. Oops. And another issue is the vascular complication because the microsheath is very thicker. So we usually use this vascular closure device, which is called Parclose by Abbott. As you can see, we use this device. Then after the remove this thicker microsheath, as you can see, there are no bleeding here. So after using this device, we don't have any trouble in this hematoma or bleeding complication is around this area. So if you can use this, I definitely recommend to use this closure device for microimplantation. So this is my conclusion, ladies and gentlemen. Leadless pacemaker is not a simple alternative for transvenous pacemaker. leadless is a superior potential to traditional pacemaker. Micro VR VVI mode has a risk of heart failure in a certain patient. Micro AV VDD mode may improve this issue. So there are some tips to reduce the complication and improve the pacing threshold. Thank you for your attention.
Thank you for your nice presentation, Dr. Fukaya. I have a simple question. As you listed many indications about the leadless pacemaker, actually the European guidelines list 3 about this. First one is pocket infection, and the second one is transvenous lead access cannot be available, and the third one is hemodialysis patient. What is your usual indication for the leadless pacemaker in your real practice?
Thank you for a good question.
Because the leadless pacemaker is very expensive in Korea because of the reimbursement issue. So we are very interested in about the indication. Which indication is very best for the patient?
Thank you. Actually, the most frequent indication in our hospital is after the lead extraction due to infection or other issue. And also the hemodialysis patient, we don't want to use the vascular access. But in higher age patients, such as 85 or 90, 95 patient, and with the less requirement of the pacing, we choose the leadless pacemaker.
Okay. Is there any question for Dr. Luigi?
Yeah. I enjoyed your talk, Dr. Fukaya.
Thank you.
You have also implanted the VDD micra, right, Dr. Fukaya? Can you share with us the atrial tracking experience with the VDD micra, if it really is able to track very well in patients with sinus rhythm and AV block?
Thank you. Good question. Yes, in Japan, we can use the micra AV, which is a VDD mode of the micra. I have not many experience about the micro AV because we could use the about 1 year or so.
Okay.
But the surprisingly, the atrial detection is very nice. So in our experience, over than 80 or 85, sometimes over the 90% of atrial contraction can be detected by the micro AV. I think it's very nice, and it may change our practice.
Thank you.
Thank you.
Okay, thank you. Let me introduce my co-chair, Dr. Luigi Segundo, and he will take over the last 3 speakers. Dr. Luigi, are you ready for?
Yes, thank you, Dr. Jang. Happy to introduce the next speakers. Our next speaker is an associate professor, Division of Cardiology, Department of Internal Medicine and Electrophysiology at the Catholic University of Korea, Cardiovascular Center in Seoul at St. Mary's Hospital, to give a talk on the choice of cardiac implantable electronic device in sarcoidosis complicated with AV block or ventricular tachycardia or ventricular fibrillation, timing and candidate identification. Please welcome Dr. Sung-Hwan Kim.
Thank you. Thank you for the kind introduction. I'm Kim Sung-Hwan, Seoul St. Mary Hospital, Korea. My topic is for cardiac device in patient with sarcoidosis. Sarcoidosis is a systemic granulomatous disease of unknown causes with various clinical presentations. If sarcoidosis patient had no cardiac involvement at the timing of device implantation, physician should consider cardiac involvement in the future?
Dr. Kim,
Yeah.
would you please share your slide? We cannot see your slide.
Let's see. Can you see my slide?
Okay, good.
Yes,
Yes,
that's it.
sorry. Yes. Yes, sarcoidosis is a systemic granulomatous disease of unknown causes with various clinical presentation. If sarcoidosis patient had no cardiac involvement at the timing of device implantation, a physician should consider cardiac involvement in the future. A patient with cardiac sarcoidosis is known to have poorer prognosis than patient with sarcoidosis without cardiac involvement. Half of patients with cardiac sarcoidosis has lung involvement, and 27% of patients has eye involvement, and 21% is skin involvement. This is the largest multicenter registry of patients with cardiac sarcoidosis, Illuminate CS registry, and published this year in European Heart Journal. Among 76 patients who present with ventricular tachycardia or ventricular fibrillation, 30 patients were already on implantable cardioverter defibrillator, and 46 patients received implantable cardioverter defibrillator after diagnosis. During a median follow-up period of 3 years, 148 combined events were observed. Combined event means all-cause mortality and heart failure admission and fatal ventricular arrhythmia. And 46 patient heart failure rehospitalization, and 99 documented fatal ventricular arrhythmia, and 49 all-cause deaths. Let me half of patients with cardiac sarcoidosis suffered from atrioventricular block, and 16 patients who experienced ventricular tachycardia or ventricular fibrillation. This figure shows the cumulative incidence with estimated 5 years and 10 years event rate. 5 years event rate of primary endpoint is composite of all-cause deaths and heart failure hospitalization, and fatal ventricular arrhythmia is 30% at 5 years and about 40% at 10 years. All-cause mortality is 10% at 5 years and 18% at 10 years. Is lower than expected previously, and heart failure hospitalization is 12% at 5 years and 20% at 10 years. How about fatal ventricular arrhythmia? 20% at 5 years and 30% at 10 years. Let's move on to the device therapy. Implantable cardioverter defibrillator is a life-saving treatment as PCI for ST elevation myocardial infarction. The risk stratification is more important. Pacemaker is mainly a symptomatic treatment. Symptom correlation is important. First, I'd like to talk about pacemaker. Reversible causes of bradycardia is drug, like beta blocker, verapamil, diltiazem, digoxin, and hyperkalemia, and acute myocardial infarction. So exclusion of these factors is very important for pacemaker candidates. Bradycardia symptom is various, like dizziness, syncope, exertional dysrhythmia. Also, a sign of pathologic remodeling for low cardiac output should be evaluated, like low ejection fraction and LV enlargements. Symptom correlation is far more important than degree of bradycardia. Even if first degree AV block make intolerable symptom, undoubtedly, the patient can be candidate for pacemaker. Usually, more than most type 2 block used to make significant symptom. If a patient has undetermined symptom, more than 3-second pulse or less than 40 beat per minute of bradycardia could be indication of pacemaker. These indications apply equal to sarcoidosis patients. However, pacing mode selection can be different in patients with sarcoidosis or without sarcoidosis. These are considerations of pacing mode selection. First, bradycardia can be classified as sick sinus syndrome, atrioventricular block, and permanent atrial fibrillation with slow ventricular response. Second, ventricular pacing, especially LV apical pacing, should be reduced as little as possible. Third, sick sinus, atrioventricular block, and atrial fibrillation can be easily combined. It can be called atrial myopathy. So patients with sick sinus syndrome are more likely to develop atrioventricular block and vice versa. Atrial fibrillation is same. Yeah. Of course, additional lead insertion is much more difficult than de novo lead insertion. So preemptive lead insertion could be permitted. Pacing mode selection should be performed as these considerations. Patient with sick sinus syndrome and sarcoidosis is more likely to develop atrioventricular block in the future. Therefore, DDD mode can be selected preemptively. Usually, AAI pace mode is selected in the case of sick sinus syndrome. Usually, DDD upgrade rate is 10% for 5 years. It's up to 50% in case of sarcoidosis. So patient should consider the possibility of ventricular lead insertion. In addition, LV apical pacing might be harmful for LV function. Patient with sarcoidosis is vulnerable for heart failure, so unnecessary ventricular pacing should be avoided. Let's move on to implantable cardioverter defibrillator. These conditions are associated with ventricular tachycardia and ventricular fibrillation. Any disease with ventricular scar, like ischemic heart disease and non-ischemic cardiomyopathy, hypertrophic cardiomyopathy, arrhythmogenic LV dysplasia, sarcoidosis, amyloidosis, or even if surgical scar can provoke ventricular tachycardia or ventricular fibrillation. Implantable cardioverter defibrillator is considered when patient experienced aborted sudden cardiac death, sustained ventricular tachycardia, and low ejection fraction, less than 35%. It's similar with patient without sarcoidosis. In case of sarcoidosis, syncope, ventricular scar detected by MR or PET scan, and inducible ventricular tachycardia, ICD can be considered as class 2A indication. Patients who need pacemaker for bradycardia can be considered ICD upgrade as preemptive treatment. How about A-lead insertion in ICD ICD implantation. This is the largest registry for single versus dual chamber lead. This is the retrospective quote in the National Cardiovascular Data Registry, NCDR, from 2006 to 2009. Single versus dual chamber. They authors compared the single versus dual ICD chamber. Primary outcome outcomes are 1-year mortality and readmission and device-related complication within 19 days. Procedure-related complications like cardiac tamponade were much higher, about 2 times. Yeah. In patient with dual chamber lead, means A lead and ventricular lead. However, long-term morbidity or mortality was same or very similar between single lead and dual chamber lead. These results can be applied in general. However, patient with sarcoidosis is likely to develop bradycardia, like sick sinus and atrioventricular block and conduction abnormality in the intraventricular conduction disease. So a patient is likely to have conduction abnormality like sarcoidosis. Dual chamber ICD should be favored. It's published in Heart Rhythm Journal 2013. Let's summary my talk. Sarcoidosis is the systemic disease and poor prognosis in case of cardiac involvement. And so more needed to cardiac implantable electronic device, and easily combined conduction abnormalities, and dedicated pacing mode selection and ICD selection is needed. Thank you for your attention.
Thank you, doctor.
Thank you.
In your practice, since our patients with sarcoidosis, we know that it can be progressive and actually lead to heart failure. If, for example, they currently just need a simple pacemaker, do you actually consider implanting a CRT or even a more physiologic right ventricular pacing via left bundle branch or his bundle, doctor?
Yeah, good question. Practically in Korea, it's very difficult to insert ICD implantation in patient for just bradycardia pacing. So practically, I perform just pacemaker patient who need bradycardia pacing. Yeah, so it's practically impossible. Yeah, for the reimbursement policy. As my opinion, I do not think we should ICD in case of just bradycardia pacing.
Thank you. Dr. Zhang?
Yeah, the most problematic issue is how to diagnose sarcoidosis in case there is no extra cardiac involvement of sarcoid. So the biopsy does not fit to fully disclose the sarcoidosis. So my question is, Dr. Kim, in your case, do you ever put ICD in patients with cardiac sarcoidosis without cardiac involvement of sarcoidosis?
Not yet. Yeah. Yeah.
It is very difficult to diagnose sarcoidosis without.
Yeah. So recently, there are very big progress in the cardiac imaging study, like PET scan or my heart MRI. So I think we should consider to do the MRI scan or PET scan for detection and diagnosis of sarcoidosis and evaluate for non-cardiac involvement of sarcoidosis. And we should regular follow-up and correlation to the patient symptom.
Okay.
A lot more things we need to learn about sarcoidosis. Thank you, Song-Hwan.
Thank you.
I think we're ready for our next speaker. Our next speaker is a consultant interventional cardiologist and electrophysiologist. He heads the cardiology department at the CIED Military Hospital. Can we flash Dr. Al-Kabi's credentials first, if he's ready?
Hi, good morning.
All right. Good morning, Dr. Salem Al-Kabi from United Arab Emirates.
Sorry for missing my lecture at the morning, but it's unfortunately we have an urgent case.
No worries, doctor.
So let me see how we can share the screen. Okay. Do you see my screen?
Not yet. Can you try share, pressing the share screen again?
Okay. Is it? I'm sharing the screen, but you're not seeing anything?
Somebody from the team help us. Hope you're able to relax a bit, doctor, after your emergency.
Let me see. Yeah.
While Dr. Al-Kabi is trying to share his slides, he will be talking about permanent pacemaker rescue following transcatheter aortic valve replacement, timing, and candidate identification. Are you using a Keynote, doctor, or PowerPoint?
PowerPoint.
And have you tried pressing on the share screen at the Zoom?
Yes. I
And the slides aren't showing up?
Not showing up.
Oh, there. There you
No?
go. Can you?
Okay.
That's it. We see it.
Okay, good. So
Okay.
let us start. Okay, 1 second.
Slideshow. That's it.
Okay. I need to hide these things. Just 1 second. Okay. So I will be talking about the permanent pacemaker rescue following a catheter aortic valve replacement, timing, and candidate identification. My talk will be, we'll go through the following outline is the incident of pacemaker post-TAVI, mechanism of the heart block, the predictor of heart block post-TAVI, the timing of the heart block, is there any need for extended rhythm recording in a patient post-TAVR? Having a pacemaker after TAVR, is it harmful? So let us start with the case. So this is an 85 years old asymptomatic. That's her baseline ECG. If we look to the ECG, you see borderline first degree heart block and right bundle. So you can call it bifascicular, but mainly right bundle. She went through the procedure. And if you look to the pigtail and the depth of the valve, they are just injecting here in the same view. They are inflating it now. Okay, where the next, sorry, where the inflation? I think this is the. So this is the inflation. This is the ECG post the inflation, and if you look at the ECG, her BR interval still borderline 209 by the computer saying, but still right bundle. They are maybe a PACs, but they are no complete heart block. This is a 24-hour in the CCU, and clearly from the here you see they are a complete heart block at the beginning, and then she should go back and first degree heart block. She ended having a pacemaker. So when you look at the incident of the permanent pacemaker for post-TAVI, the rate of the pacemaker implantation persistent, minimum is reported to be around 6.5, but some report is about 17%. If you look to the comparing to the SAVR surgical valve replacement, the SAVR is around 3.6, but an average is around in the TAVR is 16.6. It depends on the type of valve, and also with the experience, we have been reducing a little bit of the complete heart block post TAVR, but still the percentage is not less than SAVR. When you look at it to the timing of the heart block, with the gradual improvement of the technique and the improvement of the surface, we discharge patient early, and we were able to reduce the number of the need of the pacemaker before discharge. But if you look to the number of the pacemaker that after the discharge, they are a patient, the incident of the it's climbing up, that they end having a need of pacemaker implantation later after discharging the patient. If you look to the mechanism of the heart block in the TAVR, if you look to the anatomy of the AV node and the his bundle and the left and right bundle course, you see the AV node is close to non-coronary cusp, and the his bundle is go through the membranous septum, and then if you look to this picture, they divide to the left and right as soon they reach the muscular, the beginning of the muscular septal. So during these patients, usually they have a lot of calcium, and there are a lot of factors contribute to the heart block in these patients. Sometimes the huge calcium, which is a non-coronary cusp, which can be pushed by the balloon or the bar device against the septum and press and damage the conduction system. Also, the balloon inflation and oversizing the balloon or the size of the stent, that's also can lead to the damaging of the conduction system. Also, the depth of the implantation of the valve more than the deeper it go, it may damage the conduction system. So there have been a lot of studies to try to predict which patients are at risk of developing heart block, and this is one of the meta-analysis published in 2021. And if you look to the risk factor, you will notice that the good predictor is the baseline ECG if you have Mobitz type 1 or type 2. Also, if you have a bifascicular block or a preoperative heart block or right bundle branch block, these patients, they are at risk of developing heart block after a TAVI. Yes, the age, the older you get, because they, I think, more of calcium, and plus the male is more at risk. Also, the type of valve, if you see the self-expanding valve comparing to the balloon, they are more risk. Mechanical also valve or Medtronic core valve comparing to Edward, they are also more risk of developing heart block after a TAVR. Also, this is another studies published also in 2022. Also showed that if you have a baseline ECG with the right bundle, your risk of heart block is very high. Or if you have had transit heart block before the procedure or during the procedure. Also, this is another meta-analysis of almost like 100,000 patients, and you look. They are looking for the risk factor of the patient to heart block. And if you look to this, is bifascicular block is also right bundle block. Is these patients has high risk of developing heart block post TAVR. And also the type of the valve, also risk, especially if you have, for example, Medtronic core valve. You are at risk of more risk of developing heart block comparing to Edward valve. We talked about the risk of the depth of the implantation, and this is another study. It showed that because you target to be in the annulus and you put a little bit of stress before the line of the annulus, the deeper you go, the more chance that you will touch the muscular septal, where the left bundle and the risk of left bundle branch block and heart block. So this study showed that if the patient's membranous septum length is less than 6.43 millimeter, they're at high risk of developing complete heart block. And also the depth of the implantation of the valve more than the membranous septal, your risk is very high also to develop almost 10 times. So there are a lot of factors that it may contribute to the heart block. There are some non-modifiable like an age and gender, and they are a risk factor that it can be modifiable by choosing the type of valve and trying to avoid oversizing it. The timing of the heart block, this is a study showed 181. They follow the patient after the TAVI, and none of them had a pacemaker before the TAVI. And you see that they are now, especially with the Edward valve, we see there are some cases it's happening late after discharge. And this is another study also, it's a big registry. Also, it showed again that there are cases where the heart block can happen almost later to almost 29 days post-TAVR. And this is mainly because the new valve, they are self-expanding and keep pressing in the annulus and the LVOT. So if the patient can present later, they are is this need for long-term monitoring? And so this is a TAVR study, which they took 96 patients and they did monitoring with a patch telemetry like a month before the surgery, before the TAVR procedure, and they followed with a month after, and also they extended to total of 3 months after the procedure. And they found that the monitoring patient with the before the procedure did not lead to any patient need to have a pacemaker implantation before the procedure. There are 9 patients, which is 9.4%, require pacemaker implantation after the procedure. The patient who have been discharged and followed for a month with the monitoring patch, there are 3 patients and then having pacemaker. 1 developed QRS duration of 174 and drop in ejection fraction. And the second one also, they found they developed new left bundle branch block during the follow-up of the first month, and also drop ejection fraction. They end doing device implantation, and they did his pacing. And there was one patient had the longest pause, about 5.5 seconds, and he ended having a pacemaker. the patient who have the remaining patient with a monitor for an additional 2 to 3 months, there was none of them yield that any significant arrhythmia led to implantation of pacemaker, even though they have some patients found to be flutter and there are some pause of 4 second pause. Also, this is another study. They're trying to use a smartwatch post TAVR, and they took 100 patients, given them a smartwatch, and they monitored them by the application reached to the physician. And there was 34 patient reporting an event. 29 was captured by the smartwatch, and the 20% at end ordering for a patient telemedicine monitoring. And the yield of all these events, they are about 48%. They develop left bundle branch block, and there was 5 patients. They developed 3rd-degree heart block in the follow-up by watch, and they end having a pacemaker implantation. Is the pacemaker impacting the long term for the patient who have TAVR? And the multiple study and multiple meta-analysis showed that they are patient, if looked at this dot, is the patient not receiving pacemaker. The straight line is the patient, the straight line, the patient without pacemaker. The dot line is the patient with the pacemaker. And we see that the all-cause mortality is slightly higher in the patient who receive a pacemaker. Also, this is a partner registry, which is around 2,000 patients. Also, they showed that repeat hospitalization is more in the patient who receive a pacemaker post-TAVR. Also, the death and rehospitalization also more common and significant in a patient with a new pacemaker after the TAVR. This is also meta-analysis. It's about 74 studies. And also it confirmed that the mortality is higher in a patient with the pacemaker implantation, which is the blue line. Also, the rehospitalization is more common in a patient who receive pacemaker post-TAVR. When they look to the patient type of the valve implanted, and the long-term outcome does not affect regarding the mortality in a patient who received pacemaker. They look to the ejection fraction. The patient who received a pacemaker post-implantation, they have been having slightly a drop in ejection fraction comparing to the patient who didn't receive a pacemaker. Also, this is another study. They look to the patient who have a pacemaker, and if they are pacing more than 40% or less than 40%, and you see that the patient who have been receiving high pacing percentage or more than 40%, their survival probability is lower comparing to the patient who did not receive RV pacing, which is expected, and we see it in regular pacemaker, but slightly prominent in this this group. Also, this is another study. They took like almost 2 arms. The patient who had heart block after TAVR, and one arm they did his pacing, and another arm they did non-his pacing, like regular pacing. And if you look to the ejection fraction, you see they are slightly dropping the non-his pacing patient, which is significant. As expected, the QRS duration will be shorter in the or narrower in the patient with the his pacing comparing to non-his pacing. And they found that his pacing is possible in 85%. They attempt his pacing. It's in the his or in the left bundle, and the about nine patients, 33 or 37 patients failed to implant his pacing because of high threshold. And then they moved to the lift bundle, and they were able to implant it in almost 93% of the patient. And if you look to the patient who has successful, his basing in the baseline ejection fraction slightly below 50, they have improvement in ejection fraction, even though you cannot trust this study because it's a small number of patients. This is just a sample of their ECG, which showed QRS very wide and post implantation of lift bundle basing slightly narrow. So when you look to the guideline, if you look to, you search for if there are any consensus or expert guideline, you will find only it's can be published in ACC to 2020 about what you do about the patient develop or they have some ECG change post-TAVR. And in this guideline or this recommendation that they recommend if the patient develops symptomatic bradycardia or presents on complete heart block, you implant a pacemaker. If it's a new progressive or pre-existing conduction disturbance that change post-procedure, monitor and consider EB study and pacemaker implantation. If the narrow QRS before TAVR and after TAVR, no need for anything. You just follow up a patient as a regular pace. So the take-home message, I think still the conventional pre and post operative 12-lead ECG finding is the best tool to predict the need for pacemaker. If the patient have baseline no right bundle, the low risk group, they are no right bundle, and they are no need for pacing during the procedure, okay, or after the procedure. Recommendation: remove the temporal pacemaker, discharge the patient, and regular follow-up. If the patient have a baseline right bundle branch block and no need, there was no need for pacing during TAVR procedure, and there are no sign of heart block after, just monitor for 24 hours, remove the temporal pacemaker, and maybe consider also monitoring patient with the post-procedure for 30 outpatient telemetry or frequent ECG or a Holter or a batch telemetry for about a month. If you develop any change, then you consider them high risk. The high risk group, which they have right bundle, and they develop any sign of heart block during the procedure, you implant a pacemaker. If they have no right bundle baseline, but they need pacing during the procedure, after the procedure, if they continue having 24 hours, less than 24 hours, and they recover completely, these patients, and they have no other risk factor, there are no oversizing of the valve, then you may consider outpatient monitoring for 30 days. Or consider EB study here to confirm what is HV. And the number, it varies from, there are people who take a 65, if you look at the pacemaker guideline by European 70, and there are people who consider 75 as the cut point. If the patient become dependent pacemaker more than 40 hours, you implant a pacemaker. Extensive ECG monitoring before TAVR or 2 months after TAVR is not necessarily, and in fact, it may lead to over-treatment with the permanent pacemaker. So I think most of the experts, they will recommend for the intermediate risk to be monitored for a month post-procedure. Right bundle and QRS duration continue to be the important predictor for a need for post-TAVR pacemaker implantation. His or left bundle branch pacing feasible, and it should be considered in the majority of the patient requiring pacemaker post-TAVR. And thank you.
Thank you, Dr. Al-Kabi. A very practical talk. You have shown clearly how AV block is very common after TAVR In fact, it can happen late, 2 to 3 months after the procedure. But in your own practice, have you encountered patients recovering from AV block, maybe after interrogation of the pacemaker? And does that influence your choice of device and programming?
You mean if they develop a heart block during the procedure?
And then they recover maybe weeks later on? Do you encounter these patients of not much pacing maybe?
To be honest with you, we had like 2 patients where they are become not dependent in the pacemaker, which is not uncommon. You see it in post-surgical, and you see it post-TAVR. I will consider it, if you look to the literature, maybe around 40, it can reach to 60% what you implant, because you see heart block, they may, in 1 year, they may not become dependent on it.
All right.
I'm Dr. Support. I'm a TAVI implanter. And how long do you wait for in case the patient have a complete heart block during the procedure? You see at the operating room, and the EKG, previous EKG is normal.
If they have a normal ECG completely and they develop complete heart block, okay, we monitor them for 24 hours. And we'll put a temporary pacemaker. We'll take them to the CCU with a temporary pacemaker. If they completely recovered, to be honest with you, my practice is to do an EB study, confirm which is HV, okay, before they discharge. If the HV within normal, below 70, I will monitor them with we have like, a patch we attach to the patient. We monitor them frequently, and we bring them to our clinic. And we ask them if they report any dizziness to come to the emergency room. During the first month, to be honest with you.
Okay. And this is depend on the type of the TAVI valve, or is this?
To be honest, we in our hospital we use only Edward valve. To be honest with you. So which is it's considered one of the low risk comparing to the other core valve. But even with the core valve, if they recover, to be honest with you, less than 24 hours, okay. And I will follow them. I will not throw because the pacemaker is not a simple thing. It's for the patient. It's something later. It's a risk from infection, from everything.
Because I think it's the radial strength of the valve may be different in very of the TAVI valve. Some is radial strength is very strong, like a core valve or Edward. But some is less, like Hydra or Portico, something like that. The radial strength may be less. Maybe compression of the conducting system may be less. I think.
So you mean if they recover
maybe
valve, you will be more comfortable to leave them. But if it's core valve, you will consider pacemaker. Or?
It's for the Edward. I think I will.
For Edward.
And in our practice, if they recover, we do an EB study. If it's a reassuring, we close monitoring them. Now we don't have only one case. He presented 3 months with a complete heart block, to be honest with you.
In some case, I put the permanent pacemaker immediately after TAVI. In that case, the patient have a previous right bundle branch block. Something like that.
I agree. The right bundle is very high risk. If if the baseline right bundle and develop any heart block, we'll blank pacemaker. To be honest with you, I agree in that. But if it's completely normal baseline, completely narrow QRS, usually if they recover less than 24 hours, I try to avoid pacemaker if it's possible. To be honest, and the AB studies.
That's a good idea. Thank you.
Would be good to compile our experience in the region, so maybe we're more guided. It's probably a combination of patient factors and the valve that is being implanted, as you pointed out, Doctor. Dr. Jang?
I have no further question.
Thank you. Thank you, Dr. Alcabi. Maybe we'll
Thank
call you later again.
Okay.
And,
Thank you.
and finally, our next speaker is a cardiac electrophysiologist from Queen's Kirikit Heart Center, Khong Kaen University in Thailand, Dr. Dujao Sahatas. Welcome, Dr. Dujao.
Okay, thank you very much, Dr. Liuchi. Okay, I'm start sharing my screen. Do you see my screen?
That's it. Please
All right.
press slideshow.
Okay.
Please. That's
All
it.
right, our last talk, it's about patient with heart failure. I would like to start with a case of a 75-year-old lady with Sixana syndrome, and she was implanted dual chamber pacemaker since 2017. At that time, her ejection fraction was normal. She came to, for routine checkup at pacemaker clinic, but complained of deterioration of her functional class. So that we did ECG, and it showed that there's a new complete left bundle branch block. Echocardiogram observed here. There also, even though also preserved LV wall thickness, but ejection fraction reduced from 60 to about 30%. So coronary angiogram was done and showed 80% stenosis of mid RCA, and PCI was performed. So now, what would you do with this patient next? Whether you're going to give patient the optimal medical therapy for 3 months and then reevaluate echo, or upgrade to CRTP, or even upgrade to CIED, or just add conduction system pacing leads. All right, as we know that device for heart failure patient has two main purposes. The first is to reduce heart failure by resynchronization of the LV dysynchrony. There are two techniques right now. The traditional one is biventricular pacing, and the novel one is conduction pacing, which claim to be like through physiologic pacing. Well, previous speaker has mentioned about how we implanted the conduction system pacing, but all the implanters who want to even like to get recruit left bundle branch for his bundle pacing, you're gonna have to put the lead distal enough so that when you give an output to stim, and then you can recruit the distal part of the left bundle distal to the block. This is the ECG of patient with his bundle pacing with left bundle recruit. And this is the ECG of patient with complete, selective left bundle pacing. Well, so far the current heart failure guidelines from both societies have give a class 1 recommendation for patient with significant, electrical dysynchrony. Class 1 recommendation for biventricular pacing, because there are multiple randomized control trial like CARECHEV, CRT or companion that prove the benefit of biventricular CRT on reducing of all-cause mortality and even reverse LV remodeling. Neither of them have mentioned about the role of conduction system pacing. Well, when we look where is any guidelines that mention about the role of it, for in ACC/AHA device guideline on 2018 have mentioned a little bit on patient with mid-range of ejection fraction who need repacing or AV block. They give a 2B indication for his bundle pacing. The more recent guideline on device of the ESC guideline 2021, they give a recommendation of class 2A recommendation for his bundle pacing to be rescued, in patient who fail CS lead implantation. But they also recommend to, to implant the RV backup lead. Another 2B indication for those with EF more than 40% and need repacing more than 20%. Well, because there are no many data of conduction system pacing on this patient, on this type of patient. Well, what's the evidence now? This is the meta-analysis of patient with heart failure who's implanted his bundle pacing. They show that mean ejection fraction improved significantly from baseline, about 11%. Also, in patient with CRT indication, this is the international collaboration study group. This cohort enrolled patients who underwent left bundle pacing. Mean ejection fraction is about 30%. What they show is that left bundle pacing also improved narrow the QAS complex, and also improve the mean ejection fraction from 30 to 40% in both group, in both left bundle branch block group and then non-left bundle branch block group. What about data comparing between biventricular pacing and conduction system pacing? Well, this is a single study, observational single center study comparing patient with 3 arms of biventricular pacing, his bundle pacing, and left bundle pacing with 1 year follow-up. The narrowing of QAS complex, was observed significant, much more comparing to biventricular pacing observed in conduction system pacing from both areas. Especially the ejection improvement, the LV improvement was significant higher in conduction system pacing, like 23 and 24%, as compared to 16% of biventricular pacing. The more interesting is that the super responder rate was higher in conduction system pacing group, and even normalization of the ejection fraction was found like 70% in conduction system pacing group and about 45% in biventricular pacing group. The first randomized control trial comparing his to biventricular pacing, which is called his alternative, reported last year. They randomized 50 patients to BIV and his CRT. On intention to treat analysis, they reported that there is no significant difference of ejection fraction improvement. However, if you look in detail, we found that almost 30% of his pacing group has crossed over because they failed to recruit left bundle. So 30% crossover to BIV group, and only 4% in BIV group crossover to his group. So for protocol analysis, there is a significant improvement of ejection fraction, as compared to BIV. Well, for this year rate breaking trial on pronounced on HRS 2022 of the LBBP resync trial, it's the first randomized controlled trial comparing between LBB pacing and biventricular pacing. Dr. Su has reported that LBB pacing can increase ejection fraction, mean ejection fraction improve about 21%, significant higher than biventricular pacing, which improved about 15%. Another study also, reported, this is the non-randomized prospective, conducted in China, comparing between left bundle pacing and BIV. But this BIV is adaptive CRT, which claim that to have, the more response rate for CRT mode. So the follow-up for 1 year. The clinical outcome for this group, since they only follow up for 1 year, were comparable. But what we observe is that the improvement of ejection fraction is much significant higher in left bundle pacing group, around 20%, and improved much more than biventricular pacing group, which improved about 15% at 1 year. Also, the rate of super responder, like the previous study before, super responder rate was significantly higher in left bundle pacing group as compared to adaptive CRT group. Well, we probably look for, as all the studies I mentioned, that significant improvement of ejection fraction of the conduction system pacing group compared to BIV pacing group. What about the clinical outcome? Rate breaking trial in HRS this year again. Dr. Vijay reported the clinical outcome of the observational study, not randomized, comparing between biventricular pacing group 219 patients versus conduction system pacing group, predominantly left bundle pacing. Follow up for almost 2 years, 40% have ischemic cardiomyopathy. The improvement of QAS duration and ejection fraction exactly the same as previous study. But the clinical outcome, primary endpoint is a time to death or heart failure hospitalization, has found that these events significantly lower in conduction system pacing group as compared to biventricular pacing group. This significant driven from heart failure hospitalization. Death may be not different. All right. Another randomized control trial which is ongoing now. We just gonna have to wait for the report. But it's they randomized, 180 patients comparing between LBB pacing and BIV pacing group. I think they will finish the end of this year, and a couple more years we're probably gonna, hear the result. Well, this review is very good for new implanters to review of the connection system pacing by Dr. Sharma and Dr. Vijay, and then he gave a schematic of the mode of CRT according to pre-existing electrical disturbance. If anyone want to review this, I recommend. Well, let's move to the second purpose of the device for heart failure is to prevention of sudden death. Definite consensus for putting defibrillator for secondary prevention, but the difficult part is for primary prevention. Is there any comparison? Okay, let's observe. This slide is shown here. The trials which included in meta-analysis for proving the primary prevention in several guidelines that give class 1 recommendation. However, as you can observe from this graph, which is showing the annual event rate, of both sudden cardiac death and total mortality. As you can see here, there is a decline of event rate in the control group over time, especially lowest in Danish trial. In fact, Danish trial is the only trial that did not prove the benefit of ICD over optimal medical therapy. The reason for this is probably because of the improvement of heart failure therapy, like other speaker already mentioned about this. If we look in detail of Danish trial, 90% of population in Danish trial already received beta blockers, RAS inhibitors, and especially 60%, almost 60% have CRT that influence the prognosis. Is there any randomized comparison between CRT-D and CRT-P or not? The only randomized trial is probably this one, which is the post-hoc analysis of companion trial. For companion trial, there are 3 arms, right? Two arms of the trial is CRT-P and CRT-D, which both improve all-cause mortality as compared to optimal medical therapy. As for all overall patients, there's no significant difference in all-cause mortality between CRT-D and CRT-P. But when they stratify into ischemic and non-ischemic cardiomyopathy, surprisingly, they observed that the benefit of CRT-D was observed in patients with non-ischemic cardiomyopathy, but not in ischemic cardiomyopathy. In fact, this result contrasts to the other observational studies. This study is probably the longest cohort, I think, they conducted in UK, enrolled patients from 2000 to 2017. Longest is 16 years. Comparing between patients who got CRT-D compared to CRT-P. As the overall, it looks like CRT-D can reduce total mortality, heart failure hospitalization, death from heart failure, or even sudden cardiac death. But if you can see in baseline characteristic of these 2 groups, there are multiple, different in baseline characteristics. So they did the propensity score match for age, sex, New York Heart. Well, they only observed the benefit of CRT-D over CRT-P in patients with ischemic cardiomyopathy, but not in non-ischemic cardiomyopathy. This observational studies has identical with this meta-analysis. This is the meta-analysis which probably included largest number of patients comparing between CRT-D, almost 7,000 patients, with CRT-P, around 3,000 patients. They reported that there is no significant difference in all-cause mortality between these 2 groups. Well, I think the reason is that non-ischemic cardiomyopathy is a broad name. There are multiple underlying cardiac pathologies which carrying different sudden cardiac risk. Well, there are there are ongoing study which is a randomized control trial comparing between CIED and CRTP in low risk of sudden death patient by cardiac MRI that to rule out mid-wall myocardial scar. This study will finish on 2026, and we probably gonna have to wait for the result too. Well, so far, thanks to last week on ESC conference, they announced the new guideline for ventricular arrhythmia and prevention of sudden cardiac death. They also provide the algorithm for risk stratification for primary prevention in patients with non-ischemic, like dilated cardiomyopathy or non-ischemic codes. They use the investigations like cardiac MR, genetic testing, loop recorders, or EP studies, or even family history and certain characteristics of patient to help define high risk of sudden death patient. Well, this is not like the best practice, but this is what I do in my practice. Okay. All right, I'll start with patient who has indication for biventricular pacing. I will look at overall investigation and find out what is really cause this dyssynchrony. If this because of pure electrical dyssynchrony like left bundle branch block or right bundle branch block, I prefer conduction system pacing. Or if this is RV pacing cardiomyopathy, I prefer to do conduction system pacing. And also patient with tachycardiomyopathy, who will do AV node ablation, I prefer conduction system pacing first. For bi-V pacing, I would do it as primary strategy in patient with non-specific intraventricular conduction delay, patient with ischemic cardiomyopathy with anteroseptal wall scar, have thin of the septum, it will be high risk of perforation, and the level of block may be very very low, so that it's even though you get selective capture of conduction system pacing, there's still YQS complex. Finally, you're gonna have to do like optimize left bundle optimize or hip bundle optimize CRT, and also patient with severe dilated RV, it takes time for you to get like conduction system pacing. So I will prefer biventricular pacing as first strategy. However, it's good to have plan A and plan B, because if you feel plan A, you have backup plan. Okay. Anyways, let's move to defibrillator. Okay, for primary prevention, if echocardiogram shows significant scar, I prefer to put defibrillator in patient with ischemic cardiomyopathy. For non-ischemic cardiomyopathy, there are multiple factors to consider. Like if this is extensive scar, not exclude this one. Okay, for dilated cardiomyopathy pure, if you can evaluate scar extension, or if this patient have frequent PVC or high burden PVC or VT, or if you could do genetic study, which I can't in my center, or if patient is very young, especially younger than 75, I would prefer putting the defibrillator. Anyway, it's leave to patient decision finally. So for my patient, since I think it's left bundle branch block, and I think the RCA stenosis did not explain the reduction of ejection fraction, and there is no definite scar from echocardiography. So I add the left bundle pacing lead to the patient, and then adjust the AV delay to get the narrow SQS complex. And these are echocardiographic 3 months after adding the leads. The ejection significantly improved from 30% to 50 to 60%. Thank you.
Thank you, Dr. Dujlao. As always, very helpful tip from you. So from that one slide, I gather that you sometimes, well, in the guidelines, it says, as you have mentioned, it can be used as bailout, or as you have mentioned, rescue, if we fail to put in the coronary sinus. Is that correct? Is my understanding correct that in some patients, sometimes your primary strategy is conduction system pacing if it's really the synchrony? So, so there are patients who actually undergo primary conduction system pacing in your
Yes.
case if they're wide QRS?
Yes,
You do that.
let me show my slide a little bit. Yeah. What is that? Can I see? Okay. All right. So as I show you my slides, this is
That one.
the strategy. Yes.
Yeah.
So since since the adding that there is plenty of the evidence from previous data that if you can get like selective conduction system pacing, then ejection fraction improve in this group of patients. Like left bundle branch block induced RV pacing cardiomyopathy. So in my practice, I will prefer to do this strategy as the first strategy. And then if I fail, then I move to biventricular pacing. Yep.
Thank you.
Yeah.
Dr. Jang?
A very nice presentation. I have a simple question. Do you expect that left bundle conduction system pacing prospectively replace the CLT implantation?
Well, if you ask me actually I have to say that I'm dreaming of finding the leads, which can one have purpose, that you are able to implant the lead at left bundle. It's just exactly the dream of me. I think personally, as I can show you that ejection, the super response, even normalization in a specific group of patients, especially with electrical dysynchrony, you collect electrical dysynchrony directly, probably gonna get the better. I think it will, it's just my opinion, okay? It will replace, at least equal, I think, in some group of patients, there it is, like replacing cardiomyopathy, definitely will.
Okay.
Thank you.
Thank
We
you.
just have a few minutes. Let me just try if the remaining speakers who are here would like to have just some reaction or brief conclusion, maybe. Dr. Paul Kitua from the Philippines is still here. Dr. Fukaya from Japan is still here. If you just have some brief reactions or conclusions before you close the program. Okay, I don't think we have any further comments. This was a very enjoyable session. I think you agree, Dr. Jang and Dr. Du Zhao, Professor.
And Dr. Lee.
From the comprehensive talks of our esteemed speakers, we realized that the role of cardiac implantable electronic devices have evolved into just a simple heart rate assurance to prevention of sudden cardiac death, prevention and treatment of heart failure. It's a very exciting field, and the technology is still evolving as we speak, but we must always prioritize patient factors as well, patient safety, and to individualize patient goals. And these were very much emphasized by all our speakers as well. I hope you enjoyed this talk as much as I did. On behalf of our organizers, our program director, Professor Jun Lee Lin, is here. Would you like to share some message, Professor?
No, it's really, indeed, it's a very, very attractive presentations. Well, I really learn a lot because CIED has been quite a common practice for electrophysiologists, but now it seems to be something has to be learned by all cardiologists. You are going to handle your patients with the CIED, even you are interventionist for coronary or a patient for heart failure care, or even those for AMI team, they also have to know about the ICD. I think it's important. It's a very attractive presentation today. Thank you for both chairpersons, and also for all the speakers. Thank you.
Dr. Fukaya, would you like to have some final message, Doctor?
No, in particular. Thank you for inviting me at such a great webinar. Thank you.
Then, on behalf of Dr. Jang, then I'm happy to close this session. We'd like to see you in the next ATSC Cloud meeting. Thank you and good afternoon.
Thank you.
Thank you.
Bye.
Thank you. Bye-bye.
Bye.
Bye. Okay. Bye-bye.